afternoon, everyone, and welcome to Eat, Learn, Save the Opioid Overdose Prevention webinar series. This webinar series is presented by the Palm Beach County Behavioral Health Coalition in partnership with the Health Council of Southeast Florida. This initiative is part of the Overdose Data Action Grant and is designed to provide education, tools, and resources around opioid overdose prevention, harm reduction, stigma reduction, and community-based support. All webinars in this series are free and open to the community, providers, and families. A recording of this 90-minute webinar will be made available along with a link to the attendance certificates. Everyone who attends will have two opportunities to access their certificates. At the end of the Zoom, there will be a link to access the certificate of participation. To access your CEUs, the QR code shared in our presentation needs to be completed. If you are seeking CEUs, please be sure to complete the required survey at the end. Before we begin, just a few quick notes. This session is being recorded and the link will be shared after the event. Closed captions are enabled. If needed, select More to turn on. Continuing education units are available today at no cost to you for live attendees only. Please use the Q&A feature below to submit your questions and leave your comments in the chat. We will answer as many as possible during the Q&A portion at the end. Today's topic addresses emerging issues in opioid use disorder, including rising overdose rates and the impact of policy and stigma on treatment access. Our speaker, Dr. Stephen Keehn, is a physician with HCA Florida JFK North Hospital and an expert in emergency medicine and substance use care. His experience includes working with individuals in crisis and developing innovative responses to opioid-related challenges. Today, Dr. Keehn will cover current data trends in opioid overdose, harm reduction strategies in clinical and community settings, and how stigma and policy influence recovery outcomes. Dr. Keehn, thank you so much for joining us. At this time, we will turn it over to you.
Thank you very much for having me today. I'm Dr. Stephen Keehn. I'm an emergency room physician. I'm the chief of emergency services at HCA Florida JFK North Hospital. I do a bunch in the community with EMS. I have a big passion for EMS. I was a firefighter paramedic. And interesting, the first call that I went on back in Baltimore as a EMT observer was a heroin overdose. And that was back in 1996. We're still here today, but we'll talk about this. So I went to GW for undergrad. I did their paramedic program. I went down to Nova, Southeast University, where I did my DO school, residency up in New York. I got to train at shock trauma. I went to California for my first job out of training and then moved down to Florida, work at JFK Maine, and now work at JFK North. So that's a little bit about me. One of my most exciting jobs right now is volunteering with West Palm Beach. I'm the medical director of the SWAT team. I have no disclosures. So synthetic opioids, why were they created? Well, pharmaceutical companies continued with the development of synthetic opioids. Basically, they were synthesized in the laboratory without the use of naturally occurring opium compounds throughout the 20th century. And they were basically used for humans as well as veterinary medicine. And we're going to learn today that some of the issues going on now, a lot of these medicines are actually medicines that were used for veterinary medicine. Meperidine in 1939 was a different chemical structure to morphine, but with similar pharmacological properties. It was followed in 1946 by the synthesis of methadone. In 1959, fentanyl was developed and became a leading analgesic pain medicine and anesthetic agent due to its higher potency relative to morphine. So that fentanyl is basically 50 to 100 times the strength of morphine and about 25 times the strength of heroin. It's absorbed quicker and has a shorter time of onset for the effects. More recently, over the last decade, new synthetic opioids such as carfentanil and ocfentanil, including non-pharmaceutical products, have been implicated in an international opioid crisis and the associated increase in unintentional overdoses, poisonings, and drug-related deaths. The growing number of synthetic opioids on the controlled drug market, the ability for potent products to be easily transported in relatively small amounts, such as via the Postal Service, and their associated morbidity and mortality means that they pose a serious and complex challenge to global public health. Mortality rates in North America, illegally manufactured fentanyl, and other synthetic opioids have significantly contributed to a rapidly worsening disease burden of the opioid overdose crisis. Fentanyl is a synthetic opioid that is 50 times stronger than heroin and 100 times stronger than morphine. And we said it's also 25 times stronger than heroin. Um, it's like other opioids, fentanyl use can lead to dependency and addiction. Interesting, the slide doesn't have it, but in healthcare, fentanyl used to be the most commonly abused opioid by healthcare professionals. And the reason I believe that is because it wasn't in a normal urine drug screen. So we in the ER are able to check when you do a urine drug screen, we can check for fentanyl. Sorry, we can check for opioids such as heroin, morphine, oxycodone, Percocets. We can also check for cocaine, for amphetamines, etc. But fentanyl was not listed in the urine drug screen that most ERs have access to. At JP North, we actually are able to check that. We have the fentanyl. It's now we had that. We also have the buprenorphine test, but we also have now we have a new urine drug screen that includes fentanyl, which I think is very important, and I believe a lot of hospitals have that as well. Fentanyl is the most illicit. It's the strongest when it's made outside the country, and it's basically smuggled across the borders. A triple wave of opioid deaths in the United States has been reported, with an increase in mortality related to prescription opioids in the late 1990s, and a rapid increase in heroin-related deaths beginning in 2010, followed by fentanyl and other synthetic opioids from 2014 onwards. These are not discrete waves, but overlap each other and all contribute to the overall deaths within each wave. The CDC reported that 100,306 total drug overdose deaths occurred in the 12 months to April 2021 in the United States, and that synthetic opioids were the main cause of these deaths. In Canada, 7,224 opioid-related deaths were reported in the 12 months to March 2021, and an increase of 95%, with the large majority involving fentanyl and other synthetic opioids. So you can see right here in this graph right here, here's fentanyl deaths have increased every year since 2012. And you can see how high it's gone. We actually, in Florida, had a decrease. I believe it was in this area, basically actually 2 years ago, we had a little decrease, which was a success, I think, to all the efforts that a lot of people have been doing. A lot of different facilities, EMS, they've been giving Suboxone in the field, we're doing Suboxone in the ER, having recovery coaches, social workers, and really that's something that we'll talk about that we've been doing here at our facility, which it helps us be successful with patients that need help with this epidemic. So what is fentanyl and why is it so dangerous? Well, the early opioid epidemic, overdose deaths were largely driven by a flood of prescriptions, such as hydrocodone, oxycodone, oxymorphone, and morphine. The pharmaceutical fentanyl was approved by the FDA as a pain reliever back in 1998 and was typically prescribed to patients with severe or chronic pain. As prescriptions for these drugs fell, heroin and eventually illegally made fentanyl became the main cause of opioid overdose deaths. So a lot of people, there was one thing called pill mills. A lot of people would go and get these pills, and that was more challenging for them. It was easier for them to go out to basically drug dealers and get heroin or other medicines such as fentanyl. Drug dealers mix fentanyl with other drugs such as heroin, cocaine, meth, MDMA to increase the drug's effects, sometimes without the user's knowledge. Because fentanyl is significantly stronger than opioids, doses as small as 2 milligrams can be lethal. And with users unaware of how much fentanyl they are using, it's an especially dangerous combination. I don't think I've had any patient in the ER tell me I used X number of milligrams of fentanyl. So I thought that was interesting, but scientists are able to figure out the actual milligram strength. The DEA found that 6 out of 10 fentanyl-laced fake prescription pills contain a potentially lethal dose of fentanyl. I have had patients that did not think that they were taking fentanyl, but they took a prescription pill, at least that's what they thought it was, and it had fentanyl in the medicine. And I'm able to tell you that because when I did the urine drug screen, it showed fentanyl as well as the other substances. In recent years, many first responders and some civilians have started to carry naloxone, also known as Narcan, a drug that can rapidly reverse an opioid overdose. While there isn't data available on how many overdoses have been reversed by naloxone, the Center for Disease Control and Prevention says that bystanders are present in about 46% of overdose deaths and could potentially save lives by carrying and administering naloxone. Hold there for a second. So interesting, when I joined the West Palm Beach SWAT team, I asked the SWAT team police officers, what is your fear? I have a bag that I can do a chest tube, I can do a crike, I can intubate them, I can fix their lacerations, or if they get shot or stabbed, help with their bleeding control. And that's what I'm thinking. I'm thinking of trauma, ATLS. Well, it was very interesting. What did they tell me? They told me their biggest fear is fentanyl. When they go into some of these homes, there's powder everywhere. And I have had one of the SWAT members, they did get intoxicated, because of the fentanyl that was, went up in the air. And so they didn't feel well. They got sweaty. They got, clammy. Their mental status got a little tired. They were fortunately given Narcan and did fine. But that was a big fear. Another thing, I educated the police officers in Palm Beach Shores with their canines. I'm not a veterinarian, however, I did learn that the bioavailability of these medications for dogs, they basically process the medicines like double the speed that humans do. So you have to give them double the dose. So in generally, for humans, we give 2 to 4 milligrams intranasal, but with the dogs, we're basically giving 4 to 8 milligrams. And so when the dogs walk into these rooms, the same kind of room, they step on this powder and the powder gets absorbed into the skin. So obviously if they use their mouth or nose, they're sniffing something that can go in that way too. But just touching the powder can be absorbed. So I thought that was very interesting, that was the biggest concern is fentanyl for the police officers, not trauma. So since 2016, more people have died from fentanyl overdoses than prescription opioids. The opioid overdose, you can see from 99 up to 2022. And the synthetic opioids obviously has a rise. Heroin has fallen off, as well as prescription opioids. So carfentanil, has anybody heard of carfentanil before? Well, you know what it was for, why it was designed. Interestingly, carfentanil has emerged as a dangerous additive in the illicit drug supply due to exceptional potency and low cost of synthesis and transport. Carfentanil synthetic mu-opioid receptor agonist with similar pharmacodynamic and clinical effects of fentanyl for analgesics as well as a tranquilizer. Its estimated potency is approximately 10,000 times that of morphine and 10 to 100 times that of fentanyl, based on animal studies. It's a Schedule II and increasingly detected in street drug samples found in police seizures and post-mortem autopsies. It was basically designed to euthanize elephants. If it can euthanize an elephant, it can definitely, unfortunately, euthanize a human being. And the dose of naloxone Narcan you have to give is tremendous. I've had to give one person 12 milligrams before I saw results. That was back in 2012. Midazolam is a veterinary sedative not approved for human use. Its illicit drug samples containing this often contain fentanyl and cause opioid effect-like effects in the body. There are no test strips yet to detect this particular drug. It can cause central nervous system depression and death, and alone it does not respond to naloxone. But since most samples contain an opioid, we still give that to negate the symptoms of the substance. So if somebody, we don't really know if they're on this, there's another drug we'll talk about soon, but we still give them Narcan to help wake them up. But there's no antidote that I know of to reverse this medication. Xylazine, I'm sure you've all heard about this. I'm sure you've heard of people having these terrible skin infections or ulcers or necrotic skin areas. That's because of xylazine. So historically, xylazine has been utilized in veterinary medicine for decades as an anesthetic and analgesic sedative to facilitate safe handling, diagnostic testing, and surgical procedures in large animals. Xylazine is an emerging threat to human health. It has been detected in the illicit drug supply chain, often as an adulterant. It has been more commonly added to illicit substances, most notably fentanyl, by drug makers to enhance drug effect. So basically, by this medication going with the fentanyl, it will prolong the effects of the fentanyl. So that's why it's being put in. End users are often unaware of its presence. This is alarming, given the large number of xylazine-involved overdose deaths, while laboratory detections are deficient and reversal agents are absent. So basically the same as the other medication, we still give medications like such as Narcan to wake them up and save them. The people that get these skin infections, we have to give them antibiotics generally to treat staph, strep, stuff like that. It might be PO, might be IV. They might need inpatient admission. Sometimes if the skin infection is so terrible and like necrotic, they might need hyperbarics. And one of my coworkers, colleagues, let us know the other day that he's been seeing this a lot in the Panhandle of Florida. I have seen this, at least I believe I've seen this in this area here, but not to the level that they've seen in the Panhandle. So xylazine can be swallowed, inhaled, smoked, snorted, or injected into the muscle or vein. There are no data on vaping. Intoxication mimics clonidine and tizanidine. Tizanidine is a muscle relaxer, as they all share the same mechanism of action. The most common side effects in humans include transient hypertension, secondary to the vagus nerve stimulation, bradycardia, respiratory depression, hypotension, becoming acidotic, having coma, or a decrease in your cardiac output. Other rare but very concerning side effects that can occur are areflexia, asthenia, ataxia, blurred vision, disorientation, dizziness, drowsiness, dysarthria, dysmetria, fainting, hyperreflexia, slurred speech, somnolence, staggering, coma, apnea, shallow breathing, sleepiness, premature ventricular contractions, tachycardia, meiosis, dry mouth, hyperglycemia, and diabetes. Basically, stroke symptoms. People, aren't their reflexes aren't working. They're discoordinated, having troubles with maybe hand to nose, can't really touch certain things. Their vision's blurred. They're dizzy. You worry a lot of times about maybe what's called a posterior stroke, and then they obviously have cardiac issues with the PVCs and the heart going fast. All concerning issues. Next slide. The reversal of xylazine overdose is exceptionally difficult given unestablished guidelines, the lack of reversal agents, there's no antagonist for this in human use, and the frequent concomitant mixture of other illicit drugs, most commonly with opioids. So one thing I would like to say right now this time is, in the ER, I'm seeing a lot of patients that come in and they get reversed from Narcan either by a friend, a family member, by EMS, or by us, and they say, I don't use fentanyl, I don't use opioids. Well, you received Narcan because you weren't breathing, you had pinpoint pupils, you weren't responding. You obviously got opioids, whether you thought you were taking that or not. A lot of people I see smoke marijuana, and they come in and there's been fentanyl in the marijuana. I've seen a lot of people with cocaine that they thought they were doing cocaine, but really it wasn't. Or maybe it was a combination of cocaine with fentanyl. And so that's a big concern. I mean, obviously you shouldn't be using any drugs, but when you think you're doing one medication and you're getting a different medicine, that's a big issue. But that's why I think I'm seeing a lot of people. So a lot of times I ask people that woke up after being reversed, do you want to be on Suboxone or buprenorphine? And a lot of times they say, I don't have an issue with opioids, and that's why, because they didn't realize that that's what they were getting. Although not an effective reversal agent for xylazine, Naloxone is currently the mainstay management of xylazine overdose merely because of the frequent contaminant opioid intoxication. Of note, xylazine withdrawal symptoms are currently addressed with buprenorphine. Nitazines, um, our most recent new synthetic opioid subclass to emerge and proliferate on the illicit drug market are two benzimidazoles, are also called nitazines. The first compounds from this group were invented by the Swiss pharmaceutical company CIBA in the mid 1950s. Currently, no drugs in this class are approved for medicinal use. Between 1966 and 2003, the only two benzimidazole opioid that was sporadically identified in the illicit drug supply was etonidazine, a harmful opioid described to be 1,000 times more potent than morphine in a rodent model of antinociception. It was the appearance of this medicine in 2019 that triggered a rapid expansion on the recreational drug market. This drug dominated the NSO market in the first half of 2020. So you don't know what you're getting out there. I kind of already talked about in the previous slide. You think you're doing cocaine, you're getting fentanyl. You think you're smoking weed, you're getting weed with fentanyl. It's very concerning, and I think that's why there's a huge issue. Last week I spoke in Wellington, and they had a very meaningful slides with multiple people that have passed away, and it was very emotional. Like, I'm looking at these pictures, and I have to speak after that, and I'm like, that was challenging, but it was very moving. I'm glad I saw that, but I think that's why you're not seeing a typical patient. You're seeing successful people. You're seeing people that are not, unfortunately, that have had, a lot of challenges throughout their life. But this epidemic is very disheartening, and I'm hoping that together as a team, we can really make a difference. So future studies covering more cities can shed light on whether emerging trends reported here reflect persistent differences in isotonidazole use and mortality patterns. Determining whether this involved in overdoses require a higher dose of naloxone is also a key priority, and along with the spread of fentanyl, may support increasing the standard dose of naloxone. So one thing I can say from EMS, at one point there was an episode where we had troubles getting naloxone or Narcan, and that wasn't just in one area. I think that was in the entire country. And the thing that saved people's life is honestly is airway. If you can breathe for them, if you can, make sure the airway's okay, you maybe have to intubate them, and you're breathing for them, and they're not hypoxic, you have good oxygen levels, the medications will wear off, and then they'll be better. Obviously, you don't want to just go intubate everyone just because, but that's one thing that EMS is able to do without the medication of Narcan. If we have Narcan, fantastic, but that's what we were doing when there was a time when it was very challenging to get the Narcan supply. So kratom, what is it? Well, it is it's a tree native to Southeast Asia, also called, the area Thailand, Malaysia, Indonesia, Papua New Guinea, and other countries. It refers to products derived from the tree leaves. Street names of kratom are also called kakium, thum, ketum, and biak. There's a lot, you can do the next slide. There's a lot of kava bars that people go to and get, kava or kratom. The current forms you can use are they swallow raw plant matter in capsule or powder form, mixing kratom powder into food or drinks, brewing leaves as tea, and taking liquid kratom extract. You can see they have those capsules down below. So what is the legal status? Is this legal or is it not legal? Well, it's not approved by the FDA for any medical or dietary purposes. It's not a scheduled controlled substance by the DEA. Therefore, kratom products are currently legal and accessible online and in stores in many areas of the U.S., as long as they don't market themselves as being for medical use as a dietary supplement. In Florida, in Florida, the sales of kratom products aren't permitted to people under 21 years of age. So what does kratom do? Well, you recall the reported reasons people state for using kratom. It helped them manage the drug withdrawal symptoms and cravings, especially if they use opioids. It helped them with pain, fatigue, even mental health problems such as anxiety, depression. So that all sounds positive. However, the actual effects in low doses, it actually has a stimulant effect to it. It increases your alertness, physical energy, talkativeness, and social behavior. In higher doses, it's more like a sedative. It's more like an opioid. Causes people to be relaxed, has pain relief. Concerning effects, it can make you psychotic, psychological dependency, and physiological dependence. So can you overdose on kratom? Well, overdoses attributed to kratom alone or in combination with other substances took off across Florida of 2016. And you can see right here on this map here, Florida going from Jacksonville down to Miami on the East Coast, and then also on the West Coast around Tampa. And the victims had a wide range of this in their blood. The highest concentration of people who overdosed solely on kratom. So how do you treat kratom-related substance use disorder? Well, current strategies, we can initiate opioid agonist therapy with buprenorphine, 8/2 milligrams. The 8 milligrams is the buprenorphine, the 2 milligrams is the naloxone, and you can titrate up accordingly until the patient reports relief. Nowadays, we go up to 32 milligrams is the max dose. For some pregnancy patients, one of my colleagues talked the other day up in Orlando, and they go even higher for some patients. You can use Suboxone for detox and maintenance treatments. In the Journal of Addiction Medicine, the official journal of the American Society of Addiction Medicine, they showed here that treatment of kratom withdrawal and dependence with buprenorphine/naloxone, also known as Suboxone, a case series and systematic literature review. Treatment of for kratom abuse in a contingency management-based MAT setting. They had a whole case series. Methadone, buprenorphine, and clonidine attenuate this medication withdrawal in rats. So MAT is medication-assisted therapy. Our medications that are basically the gold standard. That's the gold standard. That's the best thing that we know at this time to use for patients that have opiate use disorder. So it's the best approach to the epidemic that continues with the third wave of fentanyl and other synthetics in the following trifecta. Distribution, naloxone and naloxone products, access to MAT medications, methadone and OTPs, buprenorphine products, including newer long-acting agents such as Sublocade and Brixacti. Those medications are injected. Sublocade lasts for about 4 weeks. The Brixacti lasts for approximately a week. We also have naltrexone and long-acting naltrexone, and also naloxone for relapses that we do basically in the hospital or in the field, EMS. Access to behavioral therapies and appropriate ASAM level of care. So what can be provided? The dose varies depending on the formulation, and sometimes more than one dose is needed to help the person start breathing again, especially if fentanyl or carfentanil was involved. Fentanyl is a powerful synthetic opioid reliever. Similar to morphine, it's about 50 times more potent than heroin and 100 times more potent than morphine. Carfentanil is a tranquilizing agent for elephants, we said before, and other large mammals. This is a synthetic opioid 100 times more potent than fentanyl and 10,000 times more potent than morphine. So at JFK North, we had a ASU called the Addiction Stabilization Unit. Due to COVID and having more severe medical patients, we need a step-down unit, and which we now actually are using as a endoscopy suite. We don't have the unit anymore, but we still offer the service. So we have the addiction stabilization service, and this is kind of what we did. So when we first started out, back in end of 2019, it was really more heroin that was around, and we would do low dose inductions. And then we found when people, it was actually not heroin they were getting, it was more fentanyl they were getting, the low dose inductions made them sicker, and they put them into what's called precipitated withdrawal. And as most patients that are familiar with this, they don't want to go through precipitate withdrawal. They feel terrible. And at the time, when I was still learning myself, and I had everyone that was ER doc that worked for me, we all did the 8-hour MAT course to learn. Now it's actually a requirement for your DA license that you do this 8-hour MAT course to renew your DA license. So we did that so we had more knowledge and felt more comfortable. But I found that when we did the low dose induction, people got sick going to precipitate withdrawal. And at the time, the patients didn't want any more medicine, and we honestly didn't know better. Should we give more medicine or should we let them wait? So we let most of them wait longer for about 24 hours until they were better, and then we'd give more medicine. And at that time, they're better. In the meantime, we were giving them medicines for comfort, such as Zofran if they're nauseous, Motrin or Toradol for their pain, gabapentin for pain, Visceral if they're anxious. We also did the clonidine patch, which I found worked very well. Now, and then at that time too, we basically didn't start them on the Suboxone until they hadn't used for about 24 hours. Now there's new literature out, and we can initiate Suboxone less than 24 hours if you start at a higher dose. So we do a high dose induction, which basically is 16 milligrams. We do a 2 8 milligram sublingual strips. And if they go into precipitate withdrawal, we give them an additional 8 milligrams. If they're better after that, fantastic. If not, we give an additional 8 milligrams, and we go up to 32 milligrams. Interesting, if you look at that, I guess that fourth bullet point down, if someone gets Narcan, they feel terrible. The fentanyl has already left the receptor, and because the Narcan came in. But if we give them buprenorphine, we'll bind the receptor with that because it's a partial agonist, and they'll feel much better. And when I've given it within 2 hours of them receiving Narcan. One patient, I gave it within 5 hours, and they all did great. And literally, within 50 minutes, they start feeling better. Within a half hour, they're a new person. I've also learned that if somebody, because of holidays, because of weekends, if somebody can't get in the following day because of a holiday weekend, I try to give them a higher dose, maybe up to 32 milligrams, so that way they won't go into withdrawal, they won't have any cravings, and they're safer. Also, if you have somebody who isn't really willing to get the help and says, I want to leave, so they get the EMS brings them in, they get Narcan. If I get them Suboxone and they go ahead and use again, they will be fine because the medicine actually binds to the receptors stronger than the heroin or the fentanyl. If they don't want my help and they refuse the Suboxone, they go ahead and use again outside, the chances of them overdosing is very good. And unfortunately, they'll stop breathing, and you might have a fatality, unfortunately. So I think it's standard care. I think it's best practice to try to get the people that have overdosed Suboxone or buprenorphine, and that way it makes them feel better, as well as helps them not go through withdrawal anymore. And also, if they do overdose, they won't stop breathing. As far as pregnant patients go, it used to be you can only use Subutex. Subutex is buprenorphine by itself. You can do that. There is new literature now that you can do Suboxone as well, basically the same medicine, and they won't go into preterm labor. That was the concern at the time. So I hope that answers a lot of questions you might have. One thing I'm doing now, I'm the assistant medical director down in Miami-Dade Fire Rescue. I'm helping them with the community paramedics going out in the field. And we go out to people that have overdosed and we get them on buprenorphine. My hope is, and new literature shows this, that after 2 days of being stabilized in buprenorphine, then you can switch them to injectable, such as Sublocade or Brixadi. And I would love to be able to do that. And that way you have a full month, potentially, if you get them Sublocade, to get them into a rehab for long-term care, and they're stable. So I think that'd be a groundbreaking if we're able to do that in the field. So we were basically doing if the CAL score is above 8. Generally, the CAL score, I think it's helpful, just like with alcohol withdrawal, we use a CWAS scale. The same thing with opiates, and there's different bullet points to know. Some sources say you can start with the CAL score above 5. I think some sources have it as 8. So generally, if somebody's tachycardic, they're sweating, they're probably going to be above 8. And if they refuse the high dose induction, you can see alternatives. We can do a lower dose. You can do 8 milligrams. I found that the 2 milligrams, some people swear by that. I personally found that the higher dose works better. And we have all the comfort meds we do. Now, in general, when someone's withdrawing, think about liquid from everywhere, right? They might be vomiting, so we give them Zofran. They might have diarrhea, so we give them loperamide. They might smoke cigarettes too, and they might have a lot of cravings. You obviously can't smoke in the hospital with oxygen tanks, so we can give them a nicotine patch. And some patients aren't ready for initiation in the hospital, and that's okay. So we can also help them get a outpatient initiation. We have, which makes us successful, we have a social worker here 7 days a week in the ER, as well as we have a recovery coach who works at the healthcare district next door. And it's huge because when I talk to a patient that might be resistant to the services, when they go in and talk to the patient, it's a game changer. And without their help, we would not be as successful as we are. So that's huge. Next slide. So precipitated withdrawal, you go up on the dose of Suboxone to the max of 132 with comfort medications. That's the biggest thing. And as I said before, initiating buprenorphine will keep them from having withdrawal from cravings and also overdosing on any street medication that they find. The higher dose, up to 32 milligrams EDR, presently has little evidentiary support, but is recommended by the consensus. Actually, there was a paper recently, my colleague, Dr. Mark Severos, told me about, I believe somewhere in the northwest United States, is going with 32 milligrams all at once. And I have tried that on 5 people, 2 in the field and 3 in the ER. One person was out for 3 days and they had a large tolerance. The other one was also out of the medication for a while and wasn't going to be able to get medication the following day. So I went with the 32 milligrams. And the third person was a person that uses a high dose. They got Narcan, and so I went right with 32 milligrams, and they all did great. And recently, actually, in Orlando, I spoke the other day. There was a person that asked a question from the audience about she was surprised that Miami-Dade gave 32 milligrams, and I was actually on that call. And I asked her concern. I said, did you notice, did the patient have any respiratory depression or any altered mental status after this? And her answer was no. So I'm telling you, it's safe to do. And some people need a higher dose. I'm not doing it on every single person. Maybe down the road we will, but I think it's safe to do 60 milligrams, but some people will need a higher dose. So as far as other medications that people might be using, cocaine, we treat their complaints. Some of them might have chest pain. They might need a cardiac workup. Generally, someone with cocaine that has chest pain, we generally admit those patients. The cocaine will increase their heart rate, and we generally don't give them beta blockers. Amphetamines, you can treat the medical complaints. A lot of times people that take amphetamines, they have a very bad dental decay. And so they get what's called ANUG, acute necrotizing ulcerative gingivostomatitis. I don't want to say that fast. And so we got to make sure we treat their teeth and prevent infection. Obviously, any dental decay can go into your heart. I was a dental hygienist, and I always learn make sure you brush and floss. So I'm doing that. Alcohol, obviously you need to make sure that you help with alcohol withdrawal. When people have alcohol withdrawal, I usually give them Ativan, sometimes Valium, And I found recently phenobarbital actually helps a lot, helps them with their withdrawal symptoms. Generally, people that are alcoholics will be thiamine deficient, so I try to give them thiamine as well. If they drink a tremendous amount, you are at Wernicke-Korsakoff syndrome, and we generally give them 500 milligrams of thiamine. And if they're very sick, we admit them medically, obviously to stabilize them and make sure that they're resolved properly. So Good Samaritan law. So people are always concerned, well, am I allowed to help them? Am I going to get in trouble? Well, Florida's 9/11 Good Samaritan Act, it was passed in 2012. It protects a person who seeks medical assistance in good faith for an individual experiencing a drug-related overdose from charge, prosecution, or other penalties for possession of a controlled substance, if the evidence against them was obtained as a result of the person seeking medical assistance for an overdose victim. The same immunity applies to the victim. In 2015, the Emergency Treatment and Recovery Act was passed. It expands access to naloxone in two ways. It permits medical professionals who are permitted to prescribe drugs to prescribe and dispense naloxone to a patient or a family member, friend, or other person who has contact with a person at risk of opioid overdose. And it also permits those medical professionals to administer naloxone in an emergency. So if you're ever in a situation and you're afraid to do it, you're allowed to do it and you'll be protected. So the evolution of overdose fatalities to synthetics. From 2000 to 2006, cocaine was the leading drug associated with overdose deaths, which was replaced successfully by prescription opioids in 2007 to 2013. Heroin from 2014 to 2015, and illicitly manufactured fentanyl from 2016 to the present. In more recent years, a sharp increase in fatalities has been linked to systemic polysubstance use and potent synthetic compounds in numerous drug classes, including synthetic opioids such as fentanyl, sedatives like benzodiazepines, and stimulants such as methamphetamine and novel benzodiazepines. Recent news articles report to a high prevalence up to 78% of xylazine in fentanyl screen positive urine samples in Puerto Rico and Philadelphia, and also a steep increase in fatalities from xylazine overdose. In recent reports in Philadelphia, xylazine increased from being detected in less than 2% of cases of fatal heroin or fentanyl overdose between 2010 and 2015 to 31% of fatal heroin or fentanyl overdoses in 2019. Recently, from Baltimore, there was a large overdose, I think over 30 some people in Baltimore recently. And interesting, we always say in the ER, things come in three. You know, you have a patient with a certain diagnosis, generally you have two more patients that come in that day with it. I don't know why that is. However, with overdoses, if someone comes in overdosing with Narcan, other people that have the same issue usually go to that drug dealer to get that high. There's an expression called tracing the dragon. You know, people are at this high the first time I do it, but it's always lower. And if they hear that someone, honestly, overdose, they feel like the medicine's that strong, they want to try that so they can get to that high again, which it's pretty scary. So SAMHSA has an opioid overdose toolkit. Opioid use disorder facts, 5 essential steps to first responders, information for prescribers, safety advice for patients and family members recovering from opioid overdose. So the toolkit, well, it's actually educational and help you hopefully educate you or anyone you want to share it with. So the FDA approved the sale of Narcan over the counter in March of 2023. The Florida Department of Health announced in September 2022 that it would expand the Florida Department of Children and Families overdose prevention program to all 67 counties and distribute Narcan through local health departments. The FDA in March of 2023 approved selling the overdose reversal drug Narcan without a prescription, a move long sought by advocates to improve access to the life-saving drug. So you can go to Get Help Florida. It's isavefl.com. But Narcan is now available at Florida pharmacies without a prescription. I think that's huge. There's a evaluation. If you wouldn't mind completing, that'd be very helpful, please. And if there's any questions, it'd be my honor to take them.
Hi, Dr. Keehn. We are also very grateful that people can purchase naloxone or Narcan at pharmacies. Our organization gives it away free, as do many across the state. And in Palm Beach County, there are many resources for that. One website you can go to is isavefl, and I'll put that in the chat. But I also put in a link to requesting Narcan from us. And we also have doTERRA bags. doTERRA are pouches that can really deactivate the toxins in medications, and you can do it at home and then put it in your trash because we never want medications to go in trash, down the toilet or sink, or have be accessible to pets or people. So we have these, and we also have pill drop places across the county, over 50 locations in Palm Beach County. So there are three ways to get rid of medications, and free naloxone is a part of that. And we also, in naloxone, we have the 4 milligram Narcan, but we also have I think it's 3 milligram Revive. Is that it? And can you tell us the difference between Narcan at 4 milligram and Revive at 3 milligram? How that would impact a person?
So what I've been told is they basically work the same, but I have heard that the Revive actually has less withdrawal symptoms than the naloxone. So I've heard that's fantastic. Now in the hospital, I have not used the Revive. I haven't used an EMS either. So I actually would like to try that and see. But I've heard that's what I've been actually was at the in Orlando and I was talking to um, somebody about the medications and they said that that's the biggest thing. Do you know anything, Susan, the differences to your knowledge?
Well, I would tell you that that is what I have heard also, that it's a more kind withdrawal and not as aggressive. And and I guess that that is just better for the patient and also better for the responders, the rescuers, because they might not get that aggressiveness from the person that's coming off a high into sudden withdrawal. So I have heard it, and that's one reason that we carry it to make it more gentle.
That's excellent. So interesting. So I was a paramedic back in the day. I was a paramedic in 2000 is when I became a paramedic. And we used to learn back in the day, there's no side effects in Narcan. We used to give 2 milligrams IV basically to everybody. You can also give it down the ET tube, but or you can give it intramuscular. With recent literature, we've learned that actually with too much Narcan, you actually get pulmonary edema. And I actually had someone yesterday with this. They were doing fine. I was discharging them, then all of a sudden I listened to them. The nurse got concerned and got me. It sounded like they were in heart failure. I mean, it sounded like that much fluid, so I had to admit them. Chest X-ray actually fine, but I now do lower doses. In general, if someone overdosed, they pinpoint pupils, they're not breathing, we're bagging them, and we give them the medicine. If I give them, let's say, 2 milligrams, I'm going to wake them up. They're going to be angry. They're going to be vomiting. They're going to be very disappointed, very displeased. What if I just give them zero point 0.1 or zero point zero 0.04? Just make them breathe and don't wake them up. Don't make them miserable. Honestly, I think that's more standard of care now, and that's what I do. I try to make them just breathe a little bit. But back in the day, we were told just don't be shy, give them the full dose. So I think people nowadays are going with lower doses.
Yeah, that's what I'm understanding also from the recovery community. That's what how they've educated us on it. So thank you.
Of course. Thank you.
Thank you so much, Dr. Keene, for that informative presentation. Just learning about the other opioids such as carfentanil or substances like kratom. I actually hadn't realized that kratom was such a serious issue here in Florida as well. I've seen the cafes, but I didn't realize the impact that it's been having. So as we continue on through questions, I'd like to double check to see if you have any questions, please place them into the Q&A box on your screen at the bottom of your screen. I've also allowed permission so that everyone is able to ask questions verbally, just like Susan has. So feel free to unmute yourself if you'd like to ask a question directly to Dr. Keehn. But we'll go ahead and check our Q&A and see if there's any questions at the moment. Or again, if you'd like to ask a question, feel free to unmute yourself.
Dr. Keehn, I know that we were at a conference last week that there was discussion about the Kratom 7-0 being now considered, not being able for sale. Can you share anything on that for those that's here today?
That's a great question, Anna. I don't have any more information. Do you want to share what you remember?
Well, what I understood was that is a derivative of Kratom 7-0. It has now been made illegal in the country due to its extensive side effects from its use. I guess it's a extreme derivative of the original Kratom, and had been able to be sold, in Florida and around the country, but it's now considered by FDA a controlled substance and not being allowed to be sold. So I'm not for sure the exact what it does, but it's excessive from what the Kratom is that most people buy in the stores that you see out there now. But it is another derivative that has extremely more sensitivity to hyperactivity and other things, is my understanding from what I heard. If anyone else has anything on this presentation, it'd be great to hear from you. But that was the information that was shared at conference last week.
Interesting, Dana. I haven't taken organic chemistry in a while, but I do remember, they had those synthetic marijuanas, and the OH would be like a methyl group, and so they basically, if the marijuana has this chain, well, they add this little piece on it, then it's not marijuana anymore, and that's the whole delta 8. That's all those K2 spice. Those are all those synthetic marijuanas. They changed the I guess the organic chemistry formulation of it, and so they can't call it marijuana. They call it one of these other names. So the guy is the same thing as the kratom with the OH. So they changed the little different, and it can act similar, but also act different too. The medication.
Yeah. So Susan just shared an article in the chat for everyone if they'd like to hear further information. I know this was a hot topic at conference last week, so I wanted to be sure that all of you were familiar, knew what this was. So thanks, Susan.
Yeah, and I just corrected it, 7-OH. And
H. Okay.
I put that in and I was like, oh. I actually had a question. You had something about a cow scale, and I imagine that's a specific assessment, and if they score a certain thing, you have a protocol that goes this way. If they score under this, they go that way. Could you explain what a cow scale is? And were you saying COW, right?
Yeah, so the cow score is basically a withdrawal score. It's a clinical opioid withdrawal scale, and we use that to figure out how bad someone's doing. Are they withdrawing? So generally, if their score right now, all of our score should be 0 because we're not withdrawing, and if it's above 8, we have symptoms. If it's above, I just pulled it up. 5 to 12 is mild symptoms. 13 to 24 is moderate symptoms. 25 to 36 is moderate to severe, and above 36 is severe. So the different categories would be a resting pulse rate, sweating, restlessness, pupil size, bone or joint aches, runny nose or tearing, GI upset, tremors, yawning, anxiety or irritability, and basically piloerection, goosebumps. So if they have those symptoms, and there's different, you get between 0 and 4 points per of the different categories. Actually, one is the goosebumps goes up to 5 points.
Who knew?
Yeah, right.
But not breathing is basically a 36, right? A severe.
Yeah.
That's the one that just puts you in the ballpark of, yep, you're an overdose. We know that. All right, thank you. I had not, I've heard of different kind of assessments, but I hadn't heard of the COWS scale. So thank you for clarifying.
Right. And then for benz or alcohol withdrawal, is CIWA, CIWA is what that is.
Gotcha.
Dr. Keehn, do you want to share with them what you're seeing, daily in your practice when it comes to the number of individuals coming in with overdose, or what are
Sure.
you seeing? What's your that you're seeing on a daily basis related to this area?
So I am yesterday I worked clinically, and I think I had 3 or 4 patients that overdosed that received Narcan at our hospital. Now, I also had other people too that had dental issues, that had issues with substance abuse, and it wasn't just, they didn't come in complaining, hey, I use fentanyl, etc., or someone with an abscess on their skin. They didn't say I use fentanyl. I had to, ask them. And then there's some hesitation on being honest. But I'm seeing, I think in the ER a day, we're seeing it's not as much as it used to be. It used to be a tremendous amount. Now I think it's decreased. I think we're doing a better job, and we've helped a lot of people that need help. But I think on average for the 24-hour shift, I think we're seeing about 5 overdoses a day. At least they're withdrawing. They need help.
That's great. So, in your work with the fire rescue and the SWAT, what kind of things are you seeing there when it comes to overdoses and reversals? And are you seeing more or less? Do you feel those programs are beneficial? I know that you were part of the original core when it began several years ago, but how do you see things today compared to what you used to see?
I think so. We actually have people brought to us by fire rescue from far away. So, for instance, for a stroke, the literature showing it makes more sense to drive 20 minutes further to get them to a comprehensive center than take them to the closest facility. That way, you have someone there that can actually kind of what's called roto-rootering, the big blood clot, from the brain or the neck. That person does intervention. So we found the same thing with EMS with opiates. So don't just take any ER that maybe won't be so won't treat with dignity. I think that unfortunately that really is a thing. And so people drive us up to here because I haven't worked anywhere else in the country. I worked in New York, Georgia, California, Florida, DC. I've never worked anywhere that actually has a social worker in the ER, and we have that. And we also have a recovery coach. That's huge. And that's how we're successful. And I think with EMS, and I've talked to West Palm, I talked to EMS chief there, Tom Moran, I talked to Charlie Coyle, Palm Beach County, I spoke down in Miami-Dade, and they're working on doing this in the field. Your next step set up makes it very challenging to be successful. You can go out on the field, you find John Doe, you give him medication, you explain to him, you spend, let's exaggerate, you spend an hour with them and explain everything and answer all their questions and explain to their loved one what's going to happen. But if you don't have anywhere to send them, you're going to be running on them every single day and giving them medication. And we down in Miami-Dade, we've been doing that. We've been going to people's houses 6 days a week. They don't run on Sundays, but 6 days a week to the same person, trying to get them into somewhere. So without having places, long-term centers that are willing to help, it makes it more challenging. But West Palm Beach Fire Department, Palm Beach County Fire Rescue, Miami-Dade, they have protocols that help with that. So I'm hopeful that in the near future they'll be doing that. But with the community paramedics is really what you need to do. And then also I think the challenge is you have to partner up with the different hospitals in the area. The EMS and the hospitals have to partner up. Hey, we offer the service. If you have a patient that overdosed or you keep seeing continually, please let us know so we can go to their home or wherever they live and try to help them. So I think the only way to be successful is if we're a team and we all have to work together. And having the recovery coach, having a social worker, having the ER provider, having the long-term care facilities, all of us have to work together.
Wonderful. Thank you. Let's see here. Do we have any other questions? I feel like I saw someone who unmuted themselves. Question for you, Dr. Dr. Keehn, do you see compartment syndrome in your ER where a person passes out for an extended length of time from drug use and then wakes up and cannot move arms or legs?
Yes, I have. So compartment syndrome is taught in training, in ER residency. I have seen it many times. So compartment syndrome, basically, someone, let's say, for this example, maybe there's trauma. Maybe they lay on the ground for an extended period of time, and the tissue around that area swells and it presses on the nerve, and it gets so swollen that the compartment, instead of being this size, is now this size. You press on this size, you're going to be pressing on the blood vessels, the arteries, the veins, and it makes it very challenging for the body to be able to send blood flow, nutrients back and forth, get rid of bad stuff and send good stuff, one way. So when it happens, we diagnose that with what's called a Stryker device. We stick a needle in there, about 18 gauge, and we check the pressure. The pressure is above 20. They have compartment syndrome. And we, depending on where it is, we either have orthopedics or vascular surgery to help us with this. And they need what's called a fasciotomy. A fasciotomy is where you cut the skin, and let's say this is the skin up here, right? This is the air, this is the top skin. The tissue below here is all inflamed. Well, if you open this up, you'll allow the swelling to release. Does that make sense? So by doing that, so honestly, every ER doc does know about compartment syndrome. That's you're taught that in training, and you learn how to do it. Now, I don't do a fasciotomy. That's not my expertise. I guess if I was in the middle of nowhere, could I do it? Sure, but yeah, there's big concerns with that. They do that in the OR generally, but we check the pressure with the device, and we make the diagnosis and then call the specialist for help.
Thank you for your explanation.
My pleasure. Thank you for asking.
Would anyone, any of our attendees have any questions? Feel free to unmute yourself and ask Dr. Keehn.
Cinderella's Diana again. So Dr. Keehn, you're going to help me with this, but I think, so CORE is the Coordinated Opioid Response Initiative that originally started as the Department of Health a year or two ago under Dr. Keehn and a couple of his cohorts down in his area. And it is where fire and rescue become involved in treating individuals that have started with that they're finding need Narcan or and looking to initiate treatment in the field for opioid use disorder. So I know that Dr. Keehn and I we have a monthly call with all of our peer prescriber mentors, and the director, Stephen Teal, that's the director of the CORE now for the Department of Children and Families, joins our call every month. So we're happy to say that every county in the state of Florida, all 67, now have up and running CORE programs. Now, to the extent that they're running CORE, varies by county. I know that each individual county and each different organization uses the money how they see fit and the needs that they see in their community. But I know each of those need to work with the hospital. And I know that Dr. Keehn and I have worked with a couple of different hospitals in your all's area to help them have a better understanding about when that patient comes to the ED and where that initiation induction process began in the field, what are the next steps? So it's having that program is to hit that person on the street at that initial time of that overdose, and then hopefully share resources with them. If they need to go to the ED, take them to the ED. I know a lot of CORE's programs also have, and the community paramedic program, the doctor paramedicine program, have a lot of peers on staff, and peers can work with them. It just varies on how each county wants to develop their program. And so it's another community initiative to bring a different partner into the play of helping those individuals that are in recovery or seeking recovery or have accidentally overdosed with not knowing that they had fentanyl in a pill that they bought off the street, which I think is happening more often than what we probably all know. I know from your event you had last week. So Dr. Keehn, is there anything I missed when it comes to CORE?
No, I think that was great. I think it was very educational. There's videos online that you can get. I know Dr. Courtney Phillips helped She works for the healthcare district, and she helped actually teach me about addiction. I'm not board certified addiction medicine. I am a board certified ER doctor, and working on getting my EMS certification. But she was a big help, and also one of the gentlemen from Palm Beach County as fire rescue helped as well. This whole talk made me think of something else, and for everybody online, I hear in general um, skepticism about starting buprenorphine. Why am I switching this drug to this drug? It's the same exact thing. Well, I think that that's a misunderstanding. So let me explain the risks and the benefits. So, all right, you have someone that's going to do opiates the rest of their life. Okay, who's going to have a longer life? Someone that does buprenorphine or Suboxone, or someone that's doing fentanyl? I'm going to go with the person that's doing buprenorphine. Why? The person doing fentanyl is going to get infections. Where are they going to get infection? They're going to get infection in their spinal cord, in the cervical, thoracic, lumbar. That is one of the biggest concerns that ER docs deal with when people come in that have substance use disorder and basically IV drug abuse, and they come with back pain. You come in with low back pain, I need to MRI, not an X-ray, not a CAT scan. I need to MRI your entire spine. I've had patients that have low back pain, lumbar back pain, and guess where the spinal abscess was? It was in the cervical. If I didn't do an MRI of the cervical too, I would have missed it. Okay? So that person, not only do they need emergent surgery by a neurosurgeon, they need to be on IV antibiotics generally through midline. And the problem with that too is you have someone who has opioid use disorder, you're sending home a midline. That's a problem too. But you need to take care of this issue. My wife does cardiology, nurse practitioner. Guess what she gets to see a lot? She gets to see endocarditis, infection in the heart valves. You listen to somebody, hear a murmur, they have a fever, they might have a rash, and generally you get these rash at the base of your fingernails. And it's called splinter hemorrhages. And you have endocarditis. That's a big issue. People get skin infections. There are abscesses. We talked about this other medicine before, right? Xylazine. You're going to get an ulcer. Your skin's going to get eaten away. There's a lot of other things I'm probably not even thinking about. But there's a lot of risks with that. And plus, you can overdose. You take too much, and you stop breathing, and you die. This is safe. It's a partial agonist. You cannot overdose on buprenorphine. You can overdose on methadone. You can overdose on fentanyl. You can overdose on morphine. You can overdose on Percocet. You can overdose on oxycodone. All these full agonist medicines you can overdose on. But buprenorphine, which is a partial agonist, you cannot overdose on. So exaggeration. I give you all the buprenorphine in the world right now. I don't really know how you feel, but you wouldn't overdose. Okay? It's not possible. There's so many receptors. It's kind of like there's some other medicines too that we use that you can't overdose on, which is a good thing. So I think it will keep you stable. It won't cause you endocarditis. It won't cause you other things. Now, I did learn the other day, and I was not aware of this. So I did have someone in the audience that didn't think the medicine was the greatest because it can cause dental infection. And I looked it up, and it does cause dental cavities. However, I think that's probably also from the dental decay from probably the person not doing the best job with dental hygiene. I think it's probably also with the person getting amphetamines, meth, built in with the other stuff too. I think that's probably also causing dental decay. So, and frankly, if I had the choice, and obviously people can be treated poorly that have poor dentition, and I don't disagree with that. However, I personally, if I had the choice, for me personally, be on buprenorphine and have bad teeth, or potentially die, risk benefits. That's what we do in medicine. There's nothing without risk. Tylenol can cause a headache. Tylenol can cause nausea. Tylenol in excess can cause liver failure. So there's nothing without risk. However, moderation is what I say. And I think out of the two, I think it's a smarter decision to choose buprenorphine than to choose the IV and the illegal medicines that people are doing. Thank you.
Thank you. Thank you so much, Dr. Keehn. I have another question for you as well. Do you use, oh my goodness, I'm not going to pronounce this correctly,
Vivitrol.
Vivitrol in the ER?
I don't use Vivitrol in the ER. I don't. I use the medicines I talked about for comfort, such as Toradol, Motrin,
You
gabapentin.
have to be, yeah, had to be 7 days clean in order to start the Vivitrol shot anyway. So,
Yeah, so that's one thing I don't do. And I do know people that are my colleagues. I have one of my colleagues, Dr. Stavros, he's used it before. And with what Diane just said, the person was dishonest, said they were clean for 7 days and they weren't. And then they had to go to the ICU. They were very sick.
Mhm.
So, back in the day, going back to the ASU, when we started that unit, because of dishonesty, I got buprenorphine on the added to our urine drug screen. So I would ask someone, hey, what do you take? I could check the whole thing. And they would say, I've been taking my buprenorphine. I didn't take it yesterday or I didn't take it today. So guess what? It's a 60-hour half-life. It should be in your tox screen, right? So if your buprenorphine is not in the tox screen, doesn't show up, but you're telling me you're taking it and you're here for your dose, why is it not showing up? Because you're selling it. And that's my opinion. And maybe I don't know. Maybe there's some other reason, but I can't think of one. So you have to be a detective a little bit.
Mm, wow.
I had a question about the 2015 Emergency Treatment and Recovery Act.
Okay.
So I feel like I didn't hear it correctly. Is that when Narcan or naloxone became available for Jane Public to use?
I believe so. I believe
Okay.
that's
I feel like it said something about EMTs also, and I was like, wait, they've been using it for 40 years, haven't they? But like with an injectable thing, naloxone's been around a long time, but Narcan in a, squirted up the nose thing has been in the last 10 years. But I don't know 10 years. I'm just kind of guessing. But
I agree with that. And I'd say approximately 10 years. And personally, who we're worried. I got one needle stick before. I got a needle stick when I was teaching someone in New York and I looked away to teach them and I stuck myself. It was very scary. And so, and actually, in New York at the time, you could not test the patient without the consent. Well, this is a person that was intubated. It was 2 days of scare.
Oh my goodness.
Thankfully, they woke up and they consented, and I was able to test them. However, I prefer to use intranasal. I want myself, I want the staff, I want anyone else that gives medicine to be safe. You stick someone, they wake up, you got stuck now. What are the chances that they might have HIV, hepatitis? It's not zero. And so I'd rather give someone intranasal and maybe I get some secretions. I'd rather that than deal with a needle stick.
I had also noticed that under xylazine, you had listed a lot of symptoms that I had no clue what they were. They were all these medical terms, and then some I did. But when you kind of lumped them together and you said they're stroke-like symptoms, I had never heard that correlation. So is it something that it like impacts one half of your brain, like a stroke does?
I believe it does. I believe it does. I don't think the proof is out confirming that, but I believe it has to. Because in generally a stroke, you have two types of stroke. You have an embolic, which is a blood clot, or you have hemorrhagic, you have a bleed. Those are two types of stroke. And generally they can do the same thing. Generally hemorrhagic is worse, but one side of the body doesn't work. So the blood, let's say, the blood clot comes up here and stops right here. Now this side of my body doesn't work. The let's say if a stroke is here, my left arm, I'm sorry, my left head, my right arm, my right leg doesn't work. The face might be the same side, might be contralateral, depends on where it is in the brain. Um, and with that, you can have trouble speaking, trouble with coordination, dysarthria. So you can't touch something instead of doing perfect. And you miss it.
Mm.
And then a lot of times you worry about stroke in the back of the brain, called a posterior stroke, which is they get dizzy, they get double vision called diplopia. They dysarthria. So there's a lot of D symptoms.
And so if someone presents like having a stroke, in an ER? Is the emergency department automatically know, ooh, check for xylazine too? I know that sounds silly, but
No. So what we do is we kind of do like a pit stop. We do a quick blood sugar because hypoglycemia can cause it, low sugar. We check your blood pressure. Blood pressure is through the roof. I'm thinking it's probably more hemorrhagic, probably more bleed. But we don't know. We don't have a test for xylazine. I would activate a stroke alert immediately, and we would do a CTA of the brain. We do a CTA head and neck. That's what we do here. And I talk to a neurologist and do our blood. But the blood I don't need. It's am I going to give medication to if there's no bleed, I'm treating them like it's a stroke, and maybe this medication is causing a stroke, and there's no antidote to this medicine to say, all right, I gave antidote to xylazine, you're fine, we're good, we're stopping there. I probably would treat them like TNK and treat the stroke, which we do. I think that'd be fantastic. I did have one patient they walked in, well, they were, and I got them TNK within 16 minutes, which I thought was pretty impressive. The CMS recommends 60 minutes. We try for 45 minutes or less. So I got 16.
Thank you so much. As we're beginning to kind of wrap up the afternoon, let me double check to see if we have any more questions. All right, I don't see any questions. I'll leave the floor open for just a quick moment. If anyone has any final questions, please place it in the chat.
I would like to share with those that's on the call, the different organizations that, like I mentioned earlier, Dr. Keehn is 8 of our peer prescriber mentors that we currently have through FATA and Florida Behavioral Health Association. And these doctors, and we do have one nurse practitioner now, are available to provide technical assistance and training to any organization in the state related to opioids and the medications, and that is why we're here today as part of that. But we're happy to help any other organization that would like to learn more about the medications, the treatment, things to look for in the community related to this issue. And with next month being Recovery Month, I know that's a hot topic, and our organization is there to help those who are working with those in recovery to have a better understanding about this disorder. We have several doctors, as I said, and one nurse practitioner, but I did put my email in the chat. It's diana@floridabha.org. And feel free to reach out and we can have a quick chat to see what your needs are, and we can see if one of our doctors can assist you with that training. Again, that is free to your agency, and we're happy to help.
Thank you so much, Diana. And thank you, Dr. Keehn, and to everyone who joined us today. Dr. Keehn, that was an insightful, informative presentation.
My pleasure. Thank you for having me.
All right, so these webinars are designed to provide real tools and information to reduce overdose deaths, connect individuals and families to services, and address the stigma that too often prevents people from seeking help. Thank you again for joining us, everyone. Have a wonderful afternoon.